The gastric balloon we usually do for persons who are overweight but not necessarily obese. A BMI may be less than 30 or just around that range. You can lose about 40 to 50 pounds in 6 months, but it's more of a tool. We actually put you on a nutritional program, and that aids in your weight loss or your continued weight loss long after you remove the balloon. So it's just a kickstarter for your lifestyle changes. And it's non-surgical, it's in and out procedure. The procedure involves passing an endoscope, which is basically a flexible tube with a camera that you can look and see what's happening inside your stomach on a video screen. We look around, make sure that your stomach is fine, no ulcers, no growths. The balloon is inserted, or in some instances the balloon is swallowed, and then we inflate it with a long tube, a long catheter with some saline. It can be filled to about 600 mils, and once it's there, we detach that catheter. It stays in your stomach for about 6 months. Thereafter, we remove it. And during that time, you don't get hungry and you can only eat small amounts. We usually put persons on the same diet that they would if they had done bariatric surgery. The results that we get, that we expect with the program itself, not just the balloon, are excellent. The gastric sleeve, or vertical sleeve gastrectomy, VSG, is actually the most popular procedure at ILAP and worldwide at this point in time. It involves removing the portion of the stomach that produces hunger hormones and also expands to accommodate food. So with that area gone, you don't feel as hungry and you get filled eating small portions. Your stomach is roughly the size of a banana. After the sleeve gastrectomy, you may be only able to eat about 4 ounces of food at a time. This might sound like a really small amount, and persons wonder how it is that this can maintain their body in the long term if they're not going to lose too much weight. But your body adapts to this small amount of food, and over time it reaches a point where it levels off and your weight loss will stop. You won't get underweight, you won't lose too much weight, and end up on the other side where you're undernourished. But it requires a set type of diet that we prescribe for you at ILAP, and it requires regular follow-ups with the nutritionist to make sure that you're getting your vitamins, minerals, and the internist and myself will see you periodically to make sure that there are no deficiencies. The Roux-en-Y gastric bypass, for years this has been the gold standard in bariatric surgery. The Roux-en-Y gastric bypass involves dividing the stomach into two with a very small pouch that accepts the food being swallowed. That's about 3 to 4 ounces, and rerouting the direction that the food takes so that it does not mix with the digestive juices, and so less food is eaten, less food is absorbed, and with that you can get significant weight loss. Is also excellent for persons who have diabetes, as a cure rate for diabetes with the gastric bypass is approaching 90% in some cases, depending on how long you have the disease and how bad it is in terms of control. There are other procedures that I do not perform, like the lap band. Many persons ask if it's available. It's heavily marketed, but lap bands, they come with a higher complication rate than any other bariatric procedure, and the weight loss is unpredictable. It's less than the other procedures that are offered, and so I just frankly don't think it's worth the effort to go through surgery to lose weight, and then you're not sure if you're going to lose even 50 pounds, or you're going to end up with a lot of complications, maybe half of the time. The duodenal switch is usually reserved for persons who are extremely overweight, maybe a BMI over 50, and it involves doing a gastric sleeve, a sleeve gastrectomy, and rerouting the food as well, leaving a very short segment of bowel where the food actually mixes with the digestive juices and is absorbed. by the body. So with that, you get extreme weight loss. You may, for those persons who are larger, you may lose up to 90% of the excess weight. The problem with it is that you have a higher risk of vitamin deficiencies, and as such, it's not the frontline surgery that is prescribed for persons of a smaller weight. It can be done in stages where you just do a VSG first, and then depending on how well the weight loss is going, you may go back and do the second part of the surgery, which is to do the rerouting of the flow of food and digestive juices, and that will continue the weight loss in the long term.